I am Liz Dali. I am Liz Cancel. I am the Senior Home and Community-Based Services Policy Analyst. Thank you to join us in our 1915I office hours. This session is directed to residential setting providers, but everyone that provide services for 1915I is welcome. Um, Today, we are going to do now the welcome and introduction. Then we are going to talk about the rulemaking on pause with Cassie Levu. Then OAR's updates with Natasha Martin, case staffing with Michael and Ashley. And then Komajin is going to talk about the residential services, processes to provide to providers. And then we are going to review the upcoming webinars, Q&A, and upcoming events. Michael?
Good morning, everyone. I'm Michael Oyster. I'm the Choice Model Contract Administrator and lead for the Adult Mental Health team over at Behavioral Health. Let me just orientate you to your control panel here for Zoom. It's a little bit different if you're used to Teams or Google. In this webinar format, we not only have chat, but we also have Q&A. So later on, we will address Q&A issues. If you'd like to put those in the Q&A section, that'd be terrific. But the reality of it is, if you put it in chat, we will catch that too. So there's both Q&A and chat. For reactions, if you would want to raise your hand and ask questions verbally, you do have the hand raise function under the reactions button. So we do have that as well. If you're not seeing a button that you're expecting to see, the 3 dots and more will pop up other options. So that gives you your full panel there. So with that, I think we have everything set. You do have control, of course, over your mute and video. Don't feel obligated to be on video, but especially if you have a verbal question, it'd be great to see you. So just keep that in mind. Let's go ahead and begin with Cassie talking about rulemaking and all of that. Cassie?
Thanks, Michael. Hello, everyone. Good morning. Quick introduction for myself. My name is Cassie Levu. I use she, her pronouns, and I am the Home and Community-Based Services Policy Manager here in the Medicaid Division at OHA. I am here to give a quick update on some of our rulemaking. And some of y'all very well may have been at some of the rule advisory committees that we held, excuse me, late last year in 2024. We did have to pause our rulemaking because of some feedback that we received regarding one provision of the rules. So in conversation with internal teams, we have decided to remove the portion of the rules that was kind of causing the pause and move that to a future phase of rulemaking. So not taking that out, but really kind of restructuring and imagining how we're going to move those forward in a future phase of rulemaking so that we can move forward with things that are in our rulemaking, what we're calling our phase 2 rulemaking right now for 1915I. You'll hear about one of those really exciting updates from one of our other team members here in just a moment. But really what we're trying to do with our phase 2 rulemaking is make sure that we have a really clear pathway to implementing some needed changes that we've heard from providers and from community partners in the past. Particularly, we are adjusting the cap that is on the hours for our PCA services so that we don't see folks not being able to access PCA services because of that hours cap. So that is going through in our phase 2 rulemaking. Additionally, we will be working to, I am so sorry, y'all. My dog is whining in the background. I hope you cannot hear her. I don't know what's going on, but she's very interested. Oh, and I just lost my train of thought. I apologize. So the phase 2 rulemaking, in addition to that update, will also include updates to our definitions for severe and persistent mental illness, really with the goal of making sure that more folks can qualify for 1959 services, that we're not limiting access to those services based on the existing definition. So it will help us be able to include more personality-based disorders that people often struggle with, as well as severe and persistent mental illness or chronic mental illness diagnoses. Natasha, I'm going to put you on the spot. I apologize. What else is in our phase 2 rule?
It's left my brain what else is in our phase 2 rules. We have many phases and many rules. So we can go ahead and provide those after the office hours, once I have a chance to go run and figure it out.
That sounds good. Yeah, we'll definitely make sure to include those in greater detail in the notes that we send out for y'all. But I really wanted to make sure that y'all know that if you were a part of that rulemaking rules advisory committee last fall and we're like, what the heck, where did everything end up? We did hit a little bit of a snag just because we were required to pause. We are unpausing and we'll be moving forward with the phase 2 rules. And one exciting change that we're making in the phase 2 rules, we're kind of swapping. So the piece that we had to take out to be able to unpause, we are adding something else back in there, which is going to be what I passed to Natasha to talk about. Natasha, are you ready?
I'm ready.
Okay, great.
Hi, everyone. You may not have seen my face or heard my voice yet. I'm the 1915I policy analyst, and I am here today because we've heard about providers having issues with mid certification period changes in acuity, right? My individual who I serve has had a change in acuity and they've gone up to a new tier, but they didn't change by enough points for your tier to move. I don't know how many of you have experienced this problem. The OAR in question is 410-172-0705, section 15. Right now, it reads that providers may request the IQA to perform an assessment and reauthorization of services for an individual with a significant change in acuity exceeding 20 points on the LSI instrument and lasting longer than 30 days. We have heard from you all that that change in acuity exceeding 20 points on the LSI instrument can put providers and people in a really tight spot for continuing to meet these increased needs. Therefore, we have asked from Medicaid decision makers to adjust this rule without doing a new RAC about it. Getting some message in the chat that is having a hard time hearing me, so I moved some stuff. Hopefully it's better now.
Better now, Natasha. Good job.
Great. So we're seeking to skip a RAC about this because it's really just to everybody's benefit that we adjust this. So the proposal is that we change it to providers may request the IQA perform a reassessment and reauthorization of services for an individual when there are documented significant changes in acuity lasting longer than 30 days. So really taking out that you've got to change by more than 20 points provision. Telling you all about it is part of the RAC exception request process. So that's what we're here doing today. This is the intention to add into our upcoming rule change. And really the impact here will be that with the proposed change, members and residents, their care will align with the assessed needs and acuity for appropriate services that meet those needs. So this is many such cases we've seen come through our various escalation channels. And that's it. That's what we're doing.
Do we have any questions about that for Natasha, or any questions from Cassie and talking about unpausing the rules? Not seeing any hands.
Okay, I can't help myself. One thing, Cassie and I were chatting in the background. I just really want everyone here. There was one component of this rulemaking that will be a change that we didn't bring up. I just want to say it here and we'll follow up. But the nurse delegation component will matter, and I hope will bring some relief to everyone. Cassie, do you want to summarize what's in the rule set about nurse delegation?
Yes, I can. Let me pull up the notes I have on that really quickly because I want to be able to speak to it accurately. So for nurse delegation, essentially what we're trying to do is make sure that personal care services can include nursing tasks that are typically delegated to a registered nurse under the Oregon Nurse Practice Act. So these would be services that are typically considered personal care services if the registered nurse providing them has the appropriate training and delegation. That's all going to be in accordance with our state Oregon administrative rules. As a part of this, the RN providing or being delegated those services to perform does have to train a personal care attendant on how to perform these delegated nursing tasks, really ensuring compliance with any of the guidelines that are included in that. Especially when it comes to things like in-home medical equipment or things that they need to be able to help meet the needs of that individual. So really trying to lift that burden where you have to have an RN providing those services and being able to delegate those tasks to a personal care attendant to increase the accessibility to those services.
Great, thank you, Cassie, and thank you, Holly, for highlighting that, because I know that nurse delegation can be tricky and all of that. Hopefully that will help. Cassie, I don't know if you had put out if people had any questions about the rulemaking process or any feedback about it. Is there someone that they could talk to specifically about that?
Yes, definitely. I think we are also in a little bit of a I guess I wouldn't call it a transition period necessarily, but we are trying to refine our rules practices, especially when it comes to community engagement and the rules advisory committee process, and making sure that we are reaching all of the right folks that need to be included in these rules advisory committees, giving sufficient time for folks to attend, digest the content, and then be able to participate in those rules advisory committees to the best extent that they can. I think we are also continuously always working on making sure that our rules are as plain language as possible. I know that just in myself reading them, sometimes you get really lost in some of the jargon and some of the ways that we structure those rules. So that is definitely a focus. I think not just for the Medicaid division, but across OHA as an organization, we're really trying to make sure that we are using the best practices that we know ought to be true, which is to make sure that anything is as accessible as possible.
So it sounds like that the system for feedback around the rules are being developed, and those will be pushed out soon.
Yes. So for these rules in particular, we did hold 2 rules advisory committees last year. As Natasha pointed out, this kind of swap out for that change in the OIR language around that 20-point difference for the LSI and Locus tool. That is something that wasn't included in the previous RAC, so that is why we are bringing it up here, and we'll also be including that in tomorrow's residential provider webinar that we're holding. So this is one of the ways that we can you know, be flexible in what we include in our rules and still practice weaving equity through that process as much as possible, because we don't want to include that without getting feedback from our partners and providers. So trying to maximize the opportunities that we have with y'all to let you know what's changing and get some feedback before we move forward with a process, whatever that ends up looking like.
Fantastic.
Quick question, if you guys don't mind, may I ask a question related to that rule and
Please.
provider contributions? How does it play a role when it comes to providers giving or contributing? What rule is realistic, or some of the rules are used to be fantasy for the fact that when it comes to practicing in a real world, it doesn't play the actual point of what the provider experiences on a daily basis when it comes to operation. So how can they contribute to that as a provider?
I'll jump in here, and I think that's a really good point that you bring up. Is it can you tell me how to say your first name?
First name Duo, D-E-W.
Okay, thank you so much. I think you bring up a really good point. That's our OARs are not built in a way that really align all the time with to what you said, to what happens on the ground when you're working with your clients and with the people in your facilities. So what we are trying to do is, one, create these spaces, right? So that you can come and tell OHA or tell the Medicaid division or the behavioral health division when that's happening, right? When there's a disconnect between what is an OAR and how you have to operationalize those within your settings, because every setting is different. Every group of people that you serve is different. And that means that the OARs are going to be interpreted or operationalized different. And I don't think that is the goal, right? We want to make sure that they are clear and flexible enough that they meet the needs of the people that you serve. I think the other thing is in our rules advice. Now my cat's going off. Sorry, y'all. In the rules advisory committees that we do hold, one, we have now this more robust provider list that we've been using for this office hours and our webinars, to make sure that we get the word out far and wide about when those rules advisory committees are happening and how to participate. But that's exactly the kind of feedback we would want in those spaces. If you identify through that process that the way that an OAR is written is going to conflict significantly with how you actually operationalize that within your settings, that's what we want to hear. Because we do not want to implement OARs that make it harder for you to do your job, or that throw up barriers that don't need to be there for you or for the people that you serve. So that would be exactly the right kind of feedback that we would want to hear. You can also provide written feedback. If you're not able to attend the rules advisory committees, you are welcome to send written feedback to the folks who are leading those processes, and every announcement should have your point of contact on there, so you can send that feedback directly to them. And then further down the process in our rule establishment or rule amendment process, the OARs do get posted by the Secretary of State for public comment. So there is an additional opportunity to provide some written feedback through the Secretary of State as well.
Great, thank you, Cassie. Holly?
I was just, everything. I mean, Cassie gave a very comprehensive answer, but these particular rules or rule changes did come from feedback we got from providers, things that weren't working. And that is particularly why we're making these specific changes in the program. And then Cassie gave you all the 1,000 ways you can actually impact the rules, but I just wanted to highlight that why we're making these changes is we listened to providers, and this was what they told us was the most important pieces to get right now. Now, I know there are new things that have come up since we were told that, and we will be addressing those additional things, but everything we're doing right now came from provider feedback.
Great, thank you. I do need to move us on to the next topic. Clearly, rules are important to everyone, and I think we'll have a webinar about that tomorrow with further details and all of that. So thank you, Cassie and Natasha. Let me begin the next process around case staffing. I just want to kind of give some outlines and some invitations for doing case staffings in this setting. Now, clearly, we cannot be using PHI, confidential information and the such in this kind of environment. And today we don't really have time to go through a particular case. However, we do want to invite going through situations that really depict some of the challenges that you're experiencing as a provider as it relates to the system and how we can be able to improve those processes. And often those are best done by giving an example of a client. So we do want to invite you to submit these kind of examples to us so we can be so we can prepare, set aside some time and walk through some of those processes. So please do not include names. Don't include specific situations that would be easily, we could easily determine the person if you were to tell us that information. I would also suggest describing the situation so it best highlights the situation, the challenges you are having with the system about this person. It could be around payment issues, it could be around access to treatment issues, all sorts of things. It could be around guardianship, it could be around peers, it could be around transportation, pharmacy, primary care, specialty care. I mean, I could keep on going on. There's all sorts of challenges we know of that are, it may be unique to your particular region, but then again, may be more common than what you might think with other parts of the state. So please consider those examples as you're kind of going through, especially things that would highlight system improvements. Ashley, can you
Hey,
tell us
Michael,
perhaps?
thank you.
Yeah.
Yeah, hey y'all. My name's Ashley Purdy, she, her pronouns. I am the Children's Behavioral Health Clinical Review Coordinator on the HCBS team, but the work that I do in my experience goes across the lifespan. And also I've been on the provider side for the past decade. So when y'all are talking about like case staffing or OARs and trying to figure out how do we make the rules and the practical meet with what we see on the floor, definitely want to help y'all problem solve that also. And kind of like Michael saying, right, like anything that there's barriers in terms of connecting to services with individuals, you all are the ones that know these individuals best. You see them day in and day out. So just wanting to make sure we can help bridge any gaps and consult where we can. I don't know if there's anything else you wanted me to add, Michael, but I'll toss it back to you.
Yeah, no, I think that's good. Liz, I was wanting to see if we had a central place that people could send these submissions so that we could be organized around it.
Thank you, Michael. Yeah, people can submit their case staffing when they register in the Q&A, but they also can send us an email ahead also so that we get prepared to discuss that case staffing during the office hours. I am going to post the email address that they can post of the case staffing.
Excellent, excellent. Thank you so much. Yeah, we do our best to answer we can, but if we have a little bit of a heads up, we can even be more precise and be sure that we've clarified things on our side so that we're coming across and we're communicating directly and meaningfully to the question. So thank you for submitting those in advance if at all possible. Have any questions about that? Liz, your hand is still up, but I'm guessing that you're just busy typing in things. So, all right. There we go. All right, not seeing any questions or anything like that. Let me go ahead and continue on. And get a Comagine residential service process with respect to residential providers update and discussion. Do we have Greg here? We may not.
Yes,
So,
I am here, sorry.
there we go,
And
Greg.
find the unmute button.
Fantastic. So I just want to kind of throw it over to you and the Comagine team to discuss this area for us today.
All right. Well, I think so. First of all, if others aren't aware, I am Greg Tippett. I am the Clinical Care Coordination Quality Assurance Administrator, and that is summed up basically by being the contract administrator for the Comagine Health IQA contract. And so my role is really focused on the contract and facilitating the work being done between OHA and the contractor Comagine Health. And for this discussion topic, I will go ahead and hand it off to our Comagine Health representatives. We have both Erin Bryant and Nikki Alkire here. So if you guys want to go ahead and take it away, that'd be great.
Great, thanks, Greg. I think I've had an opportunity to meet many of you, but if I haven't met you, I'm Nikki Alkire, Director of Care Management at Comagine Health, and I oversee our adult and children's program. So that includes the 1959 Home and Community-Based Services program. Erin and I just wanted to give kind of a high-level overview about Comagine's role in the 1959 Home and Community-Based Services process. So, within that, first and foremost, we make recommendations to the Oregon Health Authority in regards to initial and annual 1959 eligibility, which I know many of you are familiar with, is based on Medicaid enrollment, 21 years of age and older, a chronic mental illness or severe and persistent mental illness diagnosis, and then needing assistance with at least monthly for 2 instrumental activities of daily living. So we do determine that eligibility in the beginning and then ongoing annually. We also complete a functional needs assessment, and this is really meant to identify an individual's choice in services and supports to live in the most independent setting possible and also to engage in their community. So through this assessment process, our team prior authorizes both habilitative and psychosocial rehabilitative services and really attempts to engage not only in the individual, but also the team in the person-centered service planning process. Erin's going to go a little bit more in depth into some of our specific assessment processes and the person-centered service planning, and then our opportunities to follow up and check in throughout the course of that annual year with an individual. But I wanted to also comment that we accept referrals from any source. So we get referrals obviously from our residential partners, our county partners. We get referrals from guardians, individuals directly. Public guardian's office. So I want that to be known too, that we'll accept a referral from any source and then help whoever that referent is to get all the information needed for that full 1959 referral. Our Comagine Health webpage has a lot of information about the resources and forms. I'll drop that in the chat so that can be readily available, and we can include that in the notes as well. I think, Erin, I'll pass it over to you to kind of go in depth with a few. Erin's our senior manager, oversees the 1959 program, to maybe go a little bit more in depth with some of those processes.
Yeah, how's it going? So like Nikki said, we receive a referral from any source. So once we receive the referral, well, and again, the website that she, I think just put in the chat will have the different forms used for the different referral types as it relates to 1959 assessment referrals. Those are first received and reviewed by what we call program coordinators, and they review the documentation that you provided to make sure that we have everything we need to move forward. So all the required documentation that'll be indicated on the form that's submitted with the referral. And again, that information's on the website provided in the chat. So that'd be like a mental health assessment that's done within the last year, a treatment plan that's been completed within the last year, and progress notes as well. Once we confirm that all information is there. That information will be sent over to a behavioral health case manager, and they will reach out to schedule the face-to-face assessment with the legal guardian if applicable, the beneficiary, the provider. And as a lot of you all know, I guess the first step of that is that our case manager will contact the beneficiary or legal guardian to see what their preference of assessment is. Do they want a video assessment or do they want an in-person assessment? So that's based on the preference of the beneficiary or legal guardian. The purpose of the assessment is a few things. It's to develop the person-centered service plan. So the person-centered service plan is seeking to pull all plans and goals the individual has and needs into one larger plan. So it's going to highlight some of the goals that the beneficiary determines during the assessment with us. Goals, support needs that they have, as well as supports that will be provided by the providers, maybe the CMHP or anyone else. So for example, if they had a goal related to goals or needs, but if they had a goal related to walking every day, who on the team can help the beneficiary meet that goal and how will they help do that? Next, I should mention that after we've completed the PCSP and we send those out, in order for a plan of care to be entered in MMIS, we need signatures back from the individual or legal guardian and the provider or anyone else that's a responsible party on the person-centered service plan. So it's once we receive those back that the plan of care is entered in MMIS and billing can occur. And then our behavioral health case managers do what we call monitoring or essentially check-ins at least quarterly. So the purpose of those is to call the beneficiary, talk to them about their needs. Have there been any changes in needs? What the progress they've made towards progress or barriers toward the goals that they set during their initial meeting. And sometimes contact the provider, legal guardian, or anybody else to problem solve any barriers that the individual might be having. Again, if we use the example of a beneficiary wanting to walk every day and maybe they note that they keep forgetting to do it, maybe we would talk to the provider, say, hey, so and so is saying that they're having a hard time remembering to start their walk each day. Maybe that's a place where you could help out to remind them in the evening or something. So there's a piece for us to help bridge that gap. And also, I think I already mentioned, determining if there's any major changes in needs during the course of time since we last spoke with the individual. Also, earlier when I was discussing the assessment process, we complete the PCSP, but we also complete the LSI and the locus tool at the time of that assessment. And those are sent out, in the packet that goes to the provider, the individual, and any other applicable parties. And I think that pretty much summarizes.
I have a quick question about this, if you don't mind.
Yeah. Or no, I don't mind, rather. Sorry.
I'm not sure about this 1956, you said? 1956?
1915I. Yeah.
Can you, no, can you briefly explain us if you haven't told anyone about this before and it is something new program that I'm not aware of? Can you briefly, short and summary, tell me how that program function and when was it existed? Is it a new program or has it been there for a long time, or how does that licensing issue works?
So Cassie come off mute, so maybe Cassie, if you want to speak to that.
I'll jump in.
Okay.
Thanks, Will, for the question. It is not a new program. The team that you see here, and this is not even all of our team, is a new team around the 1959 program. And really, all you really should, the 1959 part is truly not super important to you as a provider. What's important is that this program provides services to individuals who have a chronic mental illness or a severe and persistent mental illness and require support with some of those ADLs or IADLs that Erin was mentioning. So showering, going to the bathroom, doing your grocery shopping, doing your laundry, but it also includes things like getting folks reintegrated back into their community settings. It includes providing things like individual or group therapy for folks in the residential setting. That's really what the most important thing is making sure that folks have the access to those psychosocial rehabilitative services, so that group and individual therapy and anything else that's a part of the 1959 program. And if someone can, from my team, drop the link to our 1915I webpage in the chat, that would be really great. Because I think you'll get a really good overview of what the services are for individuals. It'll go over the referral process that Nikki and Erin just outlined. And then it'll go into some resources that we have for providers. And that portion of the page, just so everyone else knows, is getting really built out with some additional resources, particularly for the residential providers. But it is not a new program, but we would be happy to send you some information, Dewo. And we're actually at the webinar tomorrow going to go over a really high level overview. So if you didn't plan to attend, I would really highly recommend it, because we will be giving just a brief introduction about what 1915 is, what the services are, and the referral process.
Excellent. Thank you so much.
No problem.
If you get a chance to, maybe before now and then, you could email me something that would give me a strong introduction before I come to the webinar. I would appreciate if you can. If you don't.
Yeah, definitely. The link, I would definitely recommend clicking on the link that both Bonnie and Liz just dropped into our chat here. That's our 1959 webpage, and that'll have a lot of information for you.
Perfect. Thank you so much.
My pleasure.
Great. Thank you, Cassie. Well, I can't help but think this is what happens when you leave a clinician in charge of moderating. I can't help but think, but see that Greg, Nikki, and Erin have these big perspectives on their backgrounds. They're looking at lots of space and air and perspective taking. So I really appreciate that, Greg, Nikki, and Erin. The next person, Bonnie, she's down in it though. She's in the grass. She's on the ground. She's there to make things happen. So let me throw this over to Bonnie.
Yeah, I'm just, my name is Bonnie Barron, she, her pronouns, and I am policy enhancement analyst for the HCBS 1959 team. And we just wanted to update you kind of what Cassie just spoke to a few seconds ago, that tomorrow we are hosting our first kind of educational webinar that will be kind of going over that high level overview of HCBS 1959, trying to get the word out now that we have a new team dedicated to this program. That's not a new program, getting that awareness out and the understanding of the referral pathways, the licensing that can happen for adult foster homes and different types of residential providers. And then, talking about the different types of engagement we're looking to offer over the next, hopefully ongoing future, to really get involved and engaged with residential providers, community mental health programs, and our community partners, and any of those providers that serve the 1959 population. So look forward to that. I know a couple of times in the chat I've seen that link pasted. We can definitely post it again at the very end, just so everybody has it kind of closer to the bottom. It does require registration. It does have the opportunity to input any questions and comments that you can kind of give us a heads up that you want us to maybe prepare for. And then we will also have Q&A function and live chat going during that webinar tomorrow as well. So we hope to hear from y'all, and the focus right now is to support residential providers, but again, just like this space, community mental health programs, CCOs, community partners are all welcome to participate in that. So we look forward to seeing you tomorrow. Thank you much. I will pass it
One,
back to maybe Michael.
one last question before you exit, please.
Yeah.
Can a group home license, which is a DD license, be able to serve this population under Oregon administrative rule?
So we are going to be talking a little bit about licensing tomorrow, and there are some allowability to have a percentage of a licensed foster home or group home serve another population, dependent upon the maximum capacity of the home and the majority of the home still being the licensed entity consumers or members. And we can definitely go in that tomorrow. If you also want to put that question in the chat, we can also give you a really more thorough answer via question and answer response as well.
Of course.
But definitely some options.
Okay.
Great, thank you.
Thank you.
Let's move to the question and answer section here. You know, we have like nearly 100 people on today's webinar, which is great. Really appreciate everyone being here. Clearly, we're not going to be able to hit every question and the such, although I haven't seen a lot of questions come. I haven't seen any questions come in. So there's your challenge. We are wanting questions. We may not always get to them during the particular time that we're meeting, but we will get back to them. The more heads up you can give us to questions, the more precise we can be. We have had 4 questions that have been sent in, and I'll just kind of go through these to see if we have experts here to help answer these questions. We may not, but if we don't, then we'll get back to you in writing and be able to get you these answers. So the first one was about how can we speed up the PCA process, the personal help me with the PCA. What does PCA
Personal
mean?
care attendant.
There we go. Personal care. I knew this, of course, but I have 1,000 things going through my head. So how can we speed those things up? Do we have someone here that can help answer that, Kathy?
Yeah, I'm gonna take that one. And
Okay.
I know for folks on this call, you might be thinking like, what do PCAs have to do with this? But as when we talk about transitioning individuals into the appropriate care settings, PCAs become really important because a lot of times folks coming out of residential settings have expressed that having someone there to help them with those ADLs or IDLs in their homes or in the community-based settings that they're a part of really supports them and really helps them maintain their stability. But we also have gotten feedback that the process to become a PCA is it takes a while. And so speaking with our personal care attendant workforce analyst who is not with us today, but if folks are interested, we can certainly invite her back to another session. We are taking steps at OHA to really shorten the wait times for personal care attendant enrollment and the prior authorization processes. Some delays are as a result of some misunderstandings about the PCA enrollment process. We do have a program that launched last year called our Provider Navigator program, which really is aimed at helping folks navigate or alleviate those challenges. In particular, the Provider Navigator program really helps guide applicants through the enrollment process and helps match them to an individual who needs behavioral health supports. We've also been working to kind of balance the caseloads that exist between our internal OHA staff and with the work that partners who you may not know are part of the process, CoMagine Health, helps us support. So really trying to find the right balance between what internal OHA staff does and what our CoMagine Health partners do. Sorry, y'all. I now have a leaf blower outside my house.
We can't hear any of that actually.
That's great. Okay,
So
I'm
your
just gonna keep
microphone's
going
doing
and
a
I
good
might
job.
be really loud.
Yeah.
And then additionally, there is a shortage of personal care attendants, just kind of overall across the state. So for individuals who need those supports as a result of a mental health challenge or a mental health need or behavioral health need, There's just not a lot of folks who really understand what that looks like. And some folks really enter the PCA workforce and find that, you know, maybe they don't have the right training, or this is not what they expected. And they move to really supporting folks who have the same needs, but not with their mental health or their behavioral health needs as a driver. So we are also in the middle of a statewide workforce recruitment campaign for to recruit more personal care attendants into the workforce, along with other types of in-home care workers, really to make sure that we are working on creating a robust workforce, not just for folks who are in residential settings, but really making sure when folks are ready to transition outside of those settings, there is enough folks in our PCA workforce to be able to support them.
Great, thank you, Cassie. I see that there's been already a question and an answer in the chat. If you'd like to take a look at that, we during these kind of webinars, we try to have multiple levels of communication. So just be aware of that. We may not necessarily talk about that, but it is being addressed live. Let me go to the next question here. We only have a few minutes left for this section. So again, if we're not able to get to your question, we will come back to it and we'll push out things in writing and clarifications. What are the steps to get a license in mental health residential program? That is a huge question, and really one for licensing. Is there someone here from licensing that could help direct questions about licensing and what's involved in the such? Is there a centralized email for that?
I actually was going to suggest, Michael, maybe we encourage, I don't know if the person who submitted this question is here, but we're going to answer those questions in the webinar tomorrow.
In the webinar tomorrow, another
yeah.
commercial for tomorrow's webinar. This is like
yeah,
the
just
sixth
commercial
one.
for the webinar tomorrow.
Right. So big stuff is happening tomorrow. Please be there. Now, still, you know, it's very detailed. So, I mean, having a connection to licensing would be important. I know there is a centralized licensing email somewhere, so maybe we can find that and push it out even afterwards here. Let me go to the next question. Do you allow providers to sign for direct placement contracts? I think David was gonna take this one. Is that right? David, are you here? David Sant?
Hi, I am here, but I don't I don't know the answer to that.
Okay.
So
Okay. I misread one of the various chats that we have going on.
that's okay.
You know, I think there's a number of things that are going on. One is, it's true, OHSU is developing direct contracts as we're building out the next phase of the residential capacity report process. One is this bed monitoring and the such, and this will be the kind of the 3.0 factor of the residential capacity process that will be client specific. It'll really help us to get back to that. We once had client-specific bed information as a state. OHSU is contracting with us to help develop this 3.0 process. So you will be having them reach out to you to onboard you to that process. It's not, I understand the misunderstanding with the perception of it being connected to the hospital. Actually, this is a separate contract. It's not necessarily hospital-based. They also monitor for hospital openings and the such. So that's in common, but actually not in relation directly to the hospital. It's for a specific contract for residential capacity bed organization. So I hope that clarifies that question, and there could be a lot more to that question, but that's the initial answer to it. This fourth question, I think I need to put on pause and go to the next topic. I think I do see a hand up. Yes.
Hi, My name is Dovana, last name Saifu. I am a group home provider for MHA clients with license for high behavioral MHA clients, and I got experience working with MHA clients for 25 years as a volunteer and as a paid professional. So now, the thing is that I see the problem is like we had a few clients very high behavior, but I mean I know how to help them because I got the experience. But the thing is, it's like my hand is tied. When crisis comes, we ask for intervention. We take them to the hospital for 3 days and return them back without any recourse. I mean, they don't do anything for it. They just put them there for 72 hours and return. Same problem happens. So as a result, right now we don't have no more clients because
Yeah.
I mean I work with this type of people in PSRB and Cascadia. People been through guidelines from 5 years to 30 years sentence, and they come through PSRB to Cascadia homes, and I have like 80% success rate. But unfortunately, I cannot do this at the group home. So
Yeah.
now I'm just asking, is there anything can be done about it?
Yeah, because of the timing and probably the details of that situation, I'll put my email in the chat, and please reach out to me so I can be able to lend you some consultation over that. Okay, I think dealing with crisis and behavioral health complexities is important, but it can be so detailed. We're kind of running out of time for today, Govana, but I will put my email in the chat. So I appreciate the question though. Let me turn this over to Liz, who will close us out for today.
Thank you so much for everyone participation. This is fantastic. Remember that our fourth Tuesday in a month is going to be directed for residential settings, but our second Tuesday in the month is directed to community mental health programs that include CCOs, county, community mental health programs in general, but everyone is welcome. I am going to post in the chat the information for our next meeting, that it's May 13. And remember that tomorrow we do have a webinar. Please join us tomorrow to get more information about residential settings and 1959 services.
Thank you, everyone.
Great, thank you. Appreciate it.
Thank you.
Have a great day.
You too.